Thank you very much, Mr. Chairman. I want to pick up right where you left off because, as you've noted, this is a bipartisan effort to end this pharmaceutical price gouging that does so much harm to American consumers and to our taxpayers. And I think we all understand that there is a lot of heavy lifting to do in the days ahead. And at the same time, I want to note that the committee has already begun to put some points on the board. Just last week, the Congress passed our bipartisan legislation Chairman and I worked on for months to stop a blatant ripoff where big pharmaceutical companies were fleecing Medicaid and taxpayers. Now, this morning, the committee is going to be looking at one of the most confounding, gnarled riddles in American healthcare today. Pharmaceutical benefit managers are among the most profitable companies in America. What these pharmaceutical benefit managers actually do to rake in all of these profits is a mystery. The deals they strike with drug makers and insurers are a mystery. How much they're pocketing out of the rebates they negotiate is a mystery. With Americans learning about schemes like spread pricing in Medicaid, whether pharmaceutical benefit managers bring any real value to taxpayers is a mystery. The pharmaceutical benefit managers are supposed to be negotiators who get a better deal, a fairer shake for the consumer on prescription drugs. What they actually are middlemen who are raking in these profits while the drug prices soar into the stratosphere. As most people will tell you, as I hear at town hall meetings continually, most Americans think that there are already too many middlemen taking a big, juicy cut out of the American healthcare system. Just a little bit of history and some basic facts. Pharmaceutical benefit managers first showed up decades ago, back when prescription drugs were being utilized more extensively. The Pbms told the insurance companies, we're the ones who know drug pricing. We'll handle the negotiations for you. But there is little evidence that these pharmaceutical benefit managers have actually held down the prices in a meaningful way. In fact, most of the evidence shows just the opposite. Pharmaceutical benefit managers actually make more money when they pick a higher priced drug over a lower priced drug. Colleagues, let's remember that all the way through this discussion. Benefit managers make more money when they pick a higher priced drug over a lower priced drug. The logic on this isn't exactly complicated graduate level economics. PBM profits are based on taking their slice of the prescription drug pie. More expensive drugs means there's a bigger pie. When there's a bigger pie, bigger slices for the pharmaceutical benefit managers. I've been looking at this issue extensively, as has the chairman, and I'm of the view that pharmaceutical benefit managers guard their operations with greater secrecy than HBO is guarding the ending of Game of Thrones. Now, we know there's never been more outrage in the country over the cost of a rising medicine. And I say that looking all the way back to my days when I was director of the Gray Panthers. If PBMs had clear, hard evidence proving that they're getting patients a better deal on prescription drugs, they'd be leafleting the countryside and shouting it from the rooftops. Instead, they work overtime to keep patients and taxpayers in the dark. Today, the committee is going to get 1,000 different versions of the same talking point. We're all about getting the best possible price for patients. But based on what I've seen so far, we're not getting actual proof. The bottom line is pharmaceutical benefit managers are middlemen who strike deals with drug makers in secret. In my experience, that kind of negotiation rarely results in an act of charity for consumers and taxpayers. Now, because of our jurisdiction, I just want to close with a few specifics with respect to the federal health programs. First, on Medicaid, a PBM scheme known as spread pricing to rip off taxpayers through Medicaid has set off alarm bells in the states from one end of the country to another. It's got nothing to do with, cream cheese, all this spread pricing, but here's how it works. The PBMs pay one set price to pharmacies for a particular drug, but then they turn around and charge Medicaid and other healthcare payers far more for the same prescription. The chairman and I are digging into this, so this will continue our bipartisan efforts. We've asked the Health Department Inspector General to take a look. If there are changes that can be made to clamp down on this exploitation of Medicare, I think it's important we consider it. The chairman and I are looking into it. It's as clear a middleman ripoff as you're going to find. Now, with respect to Medicare, some key issues. First, Part D is one of the few health benefits in America that does not have an out-of-pocket cap. That means seniors with catastrophic illnesses can face costs of thousands and thousands of dollars. These are folks on fixed incomes. This is a flaw that needs to be fixed, and I have introduced the RX cap to protect seniors in our country from having to pay more and more out of pocket for their medicine. Next, Medicare Part D encourages drug makers and PBMs to push seniors onto more expensive drugs. That's because after a certain amount of spending on drugs, seniors in Medicare are on the hook for 85% of the cost. After that point, PBMs pay only 15%. Drug makers are just home free. So it's good business for the drug industry when seniors cross that threshold as fast as possible. Second, rebates are working against the seniors who need the benefit most. Drug rebates in Part D get sent straight to the insurance companies. In theory, they use the rebates to lower premiums, which sounds good if you're healthy. It's not such a good deal for seniors who battle illnesses. The amounts they pay for their prescriptions are based on list prices, not on the prices factoring in rebates. Again, I've introduced legislation, the See-Through Act, so that patients can finally see whether these rebates are worth the trade-off, and my understanding is that there's progress on this in the House of Representatives as well. The administration has proposed new rules having to do with this topic as well. I continue to be concerned that the Trump approach could produce a windfall for the drug companies and that the administration is unprepared to take the next steps to rein in the pharmaceutical companies and bring down lists. Mr. Chairman, I appreciate very much that we're pursuing this in a bipartisan way. You mentioned insulin. Mentioned our new effort with respect to Medicaid and so-called spread pricing. Colleagues, we've got to move with urgency. 2019 is the year to get this done. We all know that 2020, there are going to be a couple things going on in America in 2020. So let's continue with a sense of urgency and get this done in 2019 and stop the price gouging. Thank you, Mr. Chairman.